This is chapter 25, part B on the urinary system. So we left off in part A talking about the three processes involved in urine formation. So we talked about step 1 with glomerular filtration. So that's going to produce our filtrate. And again, usually the cells and the proteins are too large to pass through the filtration membrane. So it'll be a cell and protein-free filtrate formation. Okay, so now we'll pick up and look at step 2 of tubular reabsorption. So in tubular reabsorption, we're going to basically return about 99% of everything that we filtered out and return it to the blood. So we don't want to lose everything in the urine. And then step 3 that we'll look at after that for tubular secretion. So that would be moving things from the blood to the filtrate and the collecting ducts to leave the body through the urine. Okay. So again, tubular reabsorption is when we're going to reclaim a lot of the contents in the filtrate and return it to the blood. So pretty much everything is going to get filtered and pushed out of that filtration membrane, but we don't want to lose all of our ions and things like that in the blood. So everything that we want to hang on to, we want to keep in the blood, we will reabsorb through the tubular reabsorption. So this is a selective process, so only certain things are going to be allowed, right, to cross that membrane, but virtually all organic nutrients are going to be reabsorbed, so those are important. We want to hang on to those. Water and ion reabsorption is going to be hormonally regulated and adjusted, so like we've talked about before in previous chapters, things like your anti-diuretic hormone can influence your water reabsorption. Aldosterone influences your sodium and water reabsorption. Okay. But when we reabsorb things, we're going to utilize both active and passive transport for tubular reabsorption. Okay. So looking at sodium first, since sodium is the most abundant cation in our filtrate. So we'll do primary active transport to move the sodium across the membrane, right, using these sodium-potassium pumps. Right? So active transport meaning we have to use ATP energy to push kind of against the gradient. Okay? So this figure is showing the solid red arrows are our primary active transport. Okay. So the reabsorption of sodium by our primary active transport is now going to provide the energy and set the conditions for reabsorbing almost every other substance after that. So remember we talked about before, I think in Anatomy 1, different types of transport. So secondary active transport is a type of transport that's made possible by our primary active transport. So that primary active transport is going to create a new electrochemical gradient, right? So we've kind of reestablished the gradient. So now we can give just a little extra push needed for transport of these other solutes. So a lot of organic nutrients can be reabsorbed through this secondary active transport mechanism, or even co-transported with sodium. So they can kind of tag along with the sodium as it's being pumped out. So some things like glucose, amino acids to make proteins, some ions, and vitamins. Right. So this is showing our secondary active transport as this dotted line. Right. So some glucose, amino acids, some ions, vitamins can, like I said, co-transport or kind of tag along with our sodium. Right. Yeah, so our primary active transport through the sodium-potassium pumps, that's going to create a new gradient that's going to allow our downhill entry of sodium and then reabsorption of those organic nutrients and ions. Right, so a passive type of transport for tubular reabsorption would be the movement of water. So again, it's going to be made possible by that primary active transport of the sodium. So we're establishing new gradients. So now the water is going to be able to passively reabsorb through osmosis. So remember, osmosis is just the diffusion of water from a low solute concentration to a high solute concentration. So it wants to go where the more concentrated solution is to try to dilute it. Right? So water is reabsorbed through special pores called aquaporins, or special channels, water channels, called aquaporins. So they're just water pores that are specialized for water transport. Okay? So there's two types of water reabsorption in the tubules. So the first type is obligatory water reabsorption. So this is going to take place in our proximal tubule, proximal convoluted tubule. Okay? So in the proximal tubule, it always has aquaporins present to reabsorb that water and return it to the blood. Right? So if something is obligatory, meaning that it has to happen. So I always use the example that I'm obligated to spend Thanksgiving with my in-laws, right? Even if I don't want to, I have to do it. I'm obligated, right? So water has to be reabsorbed in this proximal tubule. So the second type of water reabsorption in the tubule could be a facultative reabsorption. So this one only occurs under certain conditions, right? So something has to facilitate this water reabsorption, and it's going to take place in the distal convoluted tubule and the collecting ducts. So the aquaporins are only going to open or be present in these distal tubules or collecting ducts in the presence of ADH. So remember, ADH is anti-diuretic hormone, so meaning it's going to decrease urine formation. So it just means that we're going to reabsorb more of the water from the kidneys instead of letting it pass out through the urine. So we can also have some passive reabsorption of solutes in addition to water. So the solute concentration in the filtrate is going to increase as water is reabsorbed. So we're taking more water out of the filtrate and returning it to the blood. So that means there's going to be more solutes and ions and things left in the filtrate. So that's going to create another concentration gradient that's going to help to drive their passive diffusion into the tubules and the peritubular capillaries. Some substances like fat-soluble substances, ions, and urea will also be able to follow the water into those capillaries down the concentration gradient. So this is showing, so number 4, we had our reabsorption of water through osmosis through these aquaporins. So these pink channels are your aquaporins. Okay, so that's going to change the concentration of the solutes left behind. So now these solutes can be reabsorbed as they move down their gradient. So lipid-soluble substances and some various ions and urea will be able to cross into the capillaries. So the proximal convoluted tubule is going to be the site where most of our reabsorption takes place, right? So we filtered everything out of the blood in the glomerulus. So now everything that we want to keep right off the bat, we're going to return to the blood in this proximal tubule. So all nutrients, things like glucose, amino acids, proteins, vitamins, are all going to be reabsorbed, as well as majority of your sodium and water, and then some ions, uric acid, and urea. Right, so continuing down the nephron as we enter the nephron loop. So the descending limb of the nephron loop is where water reabsorption can take place. So water is able to pass through this descending loop, but solutes cannot. Right? So then as we head back up the ascending limb, now the solutes are able to pass through for reabsorption, but water generally does not. So if we need to reabsorb more water beyond the proximal tubule and this descending limb, that would be where we would release our ADH or aldosterone to increase our water absorption. Okay. The distal convoluted tubule and collecting duct. So reabsorption in these areas is going to be mostly hormonally regulated. So the distal tubules are more concerned with secretion, right? Secreting things out of the filtrate to be expelled from the body in the urine. Right? So we were talking about anti-diuretic hormone, right? So released by the posterior pituitary. So it's going to cause the collecting ducts to open up aquaporins in their membrane so we can increase our water reabsorption. Aldosterone is another hormone that can target our collecting ducts. So instead of opening aquaporin or water channels, we'll open up sodium channels so we can increase our sodium reabsorption and thereby water. So ultimate result of aldosterone, right, was to increase the blood pressure and blood volume as well as potassium secretion. Right? So remember, sodium and potassium are antagonistic or opposite. So if sodium is being reabsorbed, then potassium is going to be secreted. So another hormone we mentioned before in the endocrine system chapter, that atrial natriuretic peptide, or ANP. So it's going to be antagonistic to aldosterone. So if aldosterone causes sodium reabsorption and potassium secretion, then ANP is going to reduce sodium absorption or turn off sodium absorption. So we decrease blood volume and blood pressure. And it's released by those cells in the atria of the heart. So if blood pressure gets too high, those cells are going to become kind of overstretched because of the increase in pressure. So they'll release this hormone to kind of lower the overall blood pressure. Another hormone that can influence our reabsorption is parathyroid hormone. So it's going to act also on our distal tubule to increase our absorption of calcium. Right? So remember, parathyroid hormone is released when blood calcium is too low. So one way that we can help to increase our blood calcium is to just absorb more through the kidneys instead of losing it through the urine. Okay, so step 3 was tubular secretion. So now we've pretty much reabsorbed everything that we want to keep and return to the blood. So everything else will be secreted into the urine. Right? So tubular secretion is essentially absorption in reverse. Right? So it's going the opposite direction. And again, it occurs almost completely in this proximal tubule. So the proximal tubule is where most of the action is going to happen. And then we put the finishing final touches through the loop, and then anything extra we need beyond kind of our normal levels, we can influence with those hormones in the distal tubule. So tubular secretion is important for disposing of substances like drugs or metabolic waste that can be bound to those plasma proteins in the blood. Eliminating any undesirable substances that were passively reabsorbed, so like urea that was reabsorbed early on, will eventually secrete it toward the end of the process. We don't want to hang on to too much urea and uric acid, as those are waste products. Right? Rid the body of excess potassium, as well as helping control the blood pH by altering amounts of hydrogen or bicarbonate in the urine. So I'm just showing, reabsorption shown in blue. So most of the filtrate volume will be reabsorbed in this proximal tubule right off the bat. Everything we want to keep, we'll go ahead and reabsorb it and return it to the blood. Right? So in the loop, right, so remember the descending loop, we have water being reabsorbed. In the ascending loop, we'll have some other ions and things being reabsorbed. Right? And then the distal tubule collecting duct is going to be more hormonally regulated. So your ADH to increase water reabsorption, aldosterone for sodium and water reabsorption, parathyroid hormone for calcium reabsorption. So we can form either dilute or concentrated urine depending on our blood volume and that ADH release. So if we have an overhydration, we could produce large amounts of a dilute urine. So it have a higher water content. So our body's trying to get rid of that excess water and fluid. So as a result, your ADH production would decrease. Right? So anti-diuretic, if we're overhydrated, we need more diuresis. We need more urination. So we'll decrease and shut down production of the ADH. So that's going to decrease the number of aquaporins in that collecting duct. So that's going to decrease our water reabsorption. So most of the water, instead of being reabsorbed into the blood, is going to continue through the collecting duct and form the urine. Okay, so vice versa, if we are dehydrated, we would produce a smaller volume of more concentrated urine. So we can release kind of the maximum amount of this ADH. Um, so in severe cases of dehydration, the body is very efficient at kind of conserving water, and we can reabsorb almost 99% of the water through the kidneys. So we get dehydrated, meaning the concentration of our extracellular fluids increase. Right? They're getting more concentrated. We have less water, so we're going to ramp up the ADH production from the pituitary. So that's going to open up more of those aquaporins in our collecting duct. So more water is going to be able to be reabsorbed, right, through that collecting duct. So the end result is only a small amount of urine is going to form, and it's going to be very concentrated because it's going to have a low water content because we reabsorbed majority of our water. So diuretics are just chemicals that enhance urinary output. So like we said, anti-diuretic hormone is anti-urine formation, right? So diuretics would be pretty much anything that can inhibit your ADH hormone. So alcohol is a common ADH inhibitor. So that's why when you have a few drinks, you have to go to the bathroom a lot. And if you drink too much, you have a hangover right the next day because you've lost so much fluid, you've become dehydrated, and your electrolytes are out of whack, right? And that can cause that nausea and headache and kind of yucky feeling. Not that I would know anything about that. So sodium reabsorption inhibitors can also act as a diuretic. So remember, water is going to follow sodium. So if we block sodium reabsorption, we're also decreasing our water reabsorption. So some caffeine or drugs for hypertension and edema, where we want to kind of lose that excess body fluid. Okay. An osmotic diuretic would be a substance that's not necessarily reabsorbed, so the water is going to remain in the urine. So some larger molecules are things that kind of keep water attached to them or draw water toward them. So glucose is a common osmotic diuretic. So people that have diabetes, they have a lot of excess glucose in their blood that can lead to pulling that water from the body and have higher urine output. So clinical evaluation of the kidney function, we would use a urinalysis. So we can examine the urine for different signs of diseases, as well as testing for illegal substances and drugs. Okay. So if we were to actually assess the quality of the renal function, we would also have to look at some blood examinations. So we can measure the function of the kidneys by looking at the amount of those nitrogenous wastes in the blood, so things like your urea, uric acid. So to determine renal clearance, we would have to look at both the blood and the urine. So renal clearance is just how long does it take the kidneys to clear a particular substance in a given time. Right? So we can look at renal clearance to determine glomerular filtration rate, to make sure the kidneys are functioning properly. So if we have a longer renal clearance time, then that would mean that our filtration rate maybe has decreased or is not functioning as well. So it's not clearing and filtering out that substance as fast as we would expect it to. So chemical composition of urine is 95% water and about 5% solutes. So the nitrogenous wastes are a large component of the urine. So they are urea, uric acid, and creatinine. So urea is formed from protein and amino acid breakdown. It's going to make up the majority of the solute component. So 2% of the urine is going to be this urea, this waste product from protein breakdown. Uric acid is another common one from nucleic acid breakdown, and creatinine is formed from breakdown of that creatine phosphate. So any abnormally high concentration of any of these components or abnormal components found in the urine, such as proteins or cells, may indicate pathology or some type of disorder. Right? So remember we said Normally, you won't find cells or proteins in the filtrate in the urine because they're too large to pass through that membrane typically. Some physical characteristics, so color should be kind of a pale to deep yellow due to the urochrome pigment. So it's also one of those kind of byproducts from recycled hemoglobin. Right? So the more concentrated the urine, then the darker the yellow color will be. So if it appears clear or cloudy, that could also indicate a urinary tract infection. Some abnormal colors, pinks, browns, could be caused by food, blood, or drugs. So the drug azo or phenazodiazepine, however you say it, that you take for urinary tract infection over the counter. It kind of coats the bladder, but it also makes your urine kind of a neon orange color. So this would be kind of the ideal range of color, yellow, of urine. So anything that's kind of darker here below this line would be indicate dehydration. So odor-wise, it's only slightly aromatic when fresh, so it develops that ammonia smell after it's been standing a while because the bacteria are going to metabolize and eat that urea and some of those metabolic waste in the urine. Also, some drugs and vegetables may change the smells, like asparagus is a common one that can make your pee smell funny, or disease. Right? So patients with diabetes may have kind of an acetone type smell in their urine. So pH-wise, urine is slightly acidic, so it's ranged between 4.5 to 8. So depending on diet can also influence the pH of the urine. So a more acidic diet that has a lot of, say, proteins can cause it to become more acidic. So proteins are going to break down into amino acids, right, that are going to increase the acidity. An alkaline diet or urinary tract infections can also increase the pH of the urine. Specific gravity is kind of the concentration, so how concentrated is the urine, is that solution. So it's the ratio of the substances in the urine to the volume of water. So it ranges from 1.001 to 0.035. So the specific gravity of just pure water is 1. So we said it was 95% water and 5% solute, so that 5% of the solutes makes it a little bit higher specific gravity than just 1.0. Alright, so look at the other structures of the urinary system. So after the urine's formed in the kidneys, it's going to travel through the ureters to the bladder. So the ureters are just these slender tubes that are going to carry the urine from the kidneys down into the bladder. So as the bladder fills, the pressure inside is going to increase. So once the bladder becomes completely full, it will close off the ends of these ureters so we don't get any urine backflow up into the kidneys. Okay, so looking at the histology of the ureter wall, so there's 3 layers from the inside out. So the innermost layer is the mucosa. Right? So it's going to consist of that transitional epithelium. So remember in Anatomy 1 we looked at tissues. The transitional epithelium was the type of tissue that's able to stretch and change shape. Right? So we want the urinary system tissues to be able to stretch and change shape, like when the bladder distends. We don't want the tissue to rupture and urine leak out. The muscularis layer consists of smooth muscle that's going to contract in response to stretch and also help to propel the urine into the bladder. So gravity alone typically is not going to be enough for the urine to travel to the bladder. We also have to do some peristalsis or peristaltic kind of wave-like contractions to move the urine down into the bladder. And then the adventitia is a fibrous connective tissue on the outer surface just to help support and protect these internal structures of the ureter. Right, so then urine's going to travel from the ureter and enter into the bladder. So the bladder is just muscular sac for temporary storage of the urine. So it has openings for the ureters where they deliver the urine, and then it has an opening to the urethra where the urine will exit the body. So the trigone of the bladder shown here is kind of this triangular region, so trigone. It's just going to be the area outlined by the openings of the ureter and the urethra. Right? So the ureters are going to enter in here, and then the urethra is going to exit down through here. So when people get a urinary tract infection, they'll tend to persist in this region due to these openings and this smooth shape. So layers of the bladder wall are similar to layers of the ureter. So we have the mucosa inside composed of the transitional epithelial tissue. So the bladder tissue is able to stretch and expand without tearing or rupturing. It has a thicker muscular layer called the detrusor muscle with 3 layers of smooth muscle. Right? So we have inner and outer longitudinal layers, and then there's a circular middle layer. Right? So we're able to contract these muscles to squeeze the urine out of the bladder. Okay? And then it has a fibrous adventitia, except on this superior surface it's covered by the peritoneum. Right? So that serous membrane of the abdominal cavity is going to cover the top surface of the bladder, and then the rest of the surface of the bladder has that fibrous connective tissue, adventitia. So when the urine is empty, it's pretty much going to collapse. Right? So it has rugae, similar to what we saw in the stomach, so just those folds or ridges that allow it to expand. Okay? So a moderately full bladder can hold about a pint or 500 mils, but under necessary conditions it can hold about twice that much, right? But that's going to be about the limit. So there is a limit to how much the bladder can hold before it becomes overdistended and can potentially burst. So then the urethra is going to be the muscular tube that drains the urinary bladder and allows the urine to leave the body. So it's lined mostly with the pseudostratified epithelium, with some transitional epithelium closer to the bladder area. So we said muscular tube that drains the bladder, so it's going to contain 2 sphincters. So we have an internal urethral sphincter that's going to be involuntary smooth muscle at this bladder urethral junction. So when it contracts, it will open this sphincter to allow the urine to enter the urethra. So then the external urethral sphincter is our voluntary skeletal muscle. So this is the one that we have control over when you consciously decide to urinate. So the male urethra has a dual function. It's going to carry both sperm and urine. So there's 3 regions to the male urethra. The prostatic urethra is where it passes through the prostate gland. The intermediate part of the urethra is this tiny little section right at the urogenital diaphragm. So it's kind of tissue that's going to separate the pelvic cavity from the reproductive organs. Right? And then the spongy urethra is what's going to travel through the penis and open at that external urethral orifice. Finally, micturition is the technical term for urination. Right? Sometimes it's also referred to as voiding. So we're voiding the bladder, right, or emptying the bladder. So for micturition or urination to occur, we have to have 3 simultaneous events. Right? So we have to contract these detrusor muscles. So we have to contract and squeeze the bladder. Right? We have to open our internal urethral sphincter, and then we also have to open this external urethral sphincter, so that way the urine can leave the bladder and exit the body.